Good afternoon, ladies and gentlemen. Welcome to the webinar, which is troubleshooters in ART. Today, we are going to be discussing the thin endometrium, and I'm Dr. Durusha, the Vice President and Chair of Education Committee at Aspire, speaking to you from Mumbai, India. The implantation of an embryo depends mainly on the degree of embryo development and endometrial tolerance. And we refer endometrial tolerance to the ability of the endometrium to allow the embryo to contact, localize, adhere, and implant at a specific time, that is during the window of implantation. And this is when the embryo is most likely to implant. Endometrial thickness on ultrasound is used as a routine endometrial assessment method for assessing endometrial receptivity, which we know is very critical for a successful pregnancy as ART has advanced, and we know that we also come across some areas which we would like to troubleshoot on. And thin endometrium is one of those areas which we are all very frustrated with. And therefore today we would like to take up this episode on the thin endometrium, how we should manage it, and we will highlight on all the possibilities and potential for the new therapeutic ideas. Our panelists are well-known global experts. We have selected them very carefully because they are the ones who have covered the topic very extensively in their clinical experience. An ART clinician who has done a great amount of work in ART, a surgical infertility specialist who's excelled in reproductive surgery, and we have a great researcher who has done excellent work on the endometrium. I have these three gems for you with us today. And first of all, I'd like to introduce to you Professor T.C. Lee, who's the head of the Union Reproductive Medicine Center, Hong Kong, the Honorary Professor of Obstetrics and Gynecology, Chinese University of Hong Kong, and the immediate past president of Aspire. Jenny Lash is the principal investigator of Guangzhou Institute of Pediatrics in the Guangzhou Women and Children's Medical Center. She is widely published with over 140 papers and book chapters and is a senior editor for molecular reproduction and development and an associate editor for the journal Placenta. She's the immediate past editor of Trophoblastic Research and currently serves on the editorial board of the Journal of Reproductive Endocrinology, Immunology and Frontiers, Reproduction and Immune Tolerance. Then we have Dr. Eileen Manalo, who's currently a Professor 6 at the Department of OBGYN at the University of Philippines College of Medicine. She has recently been elected as the Assistant Secretary General of IFSS, International Federation of Fertility Societies, for the years 2022 to 2025, a well-known fertility specialist with a very busy practice and with varied interests such as recurrent pregnancy loss, repeated implantation failures, PCOS, premature ovarian insufficiency, etc., etc. So we have got three very well-established physicians with us and who are experts in this field of reproductive medicine. So today we are going to be speaking on the troubleshooting, and this is something which we will discuss further in the form of a discussion. So welcome everyone to this program, and thank you very much for sparing your time with us. I think we need to move on with the topic, and since I have already introduced you all and introduced the subject, we can go ahead with our discussion. I would like to inform our viewers that you can put in all your questions in the chat box, and we will address these questions with the experts giving in their opinion. In the meantime, we'll start our discussion and we will answer whatever we can during our time frame, and the rest will be sent to you by email, the answers to your questions. So now, first of all, I'd like to, discuss about what really is the thin endometrium? How do we define it? There are so many definitions in various articles which we read in the paper journals. So Eileen, I'll ask you what you think about the thin endometrium. What do you define it as?
Thank you, dear Ruth. I think the literature is actually unified in saying it's an endometrium which is less than 7 millimeters. Well, in fresh transfer, some say it should be less than 8, and some in frozen transfers less than 7. But generally, we talk about an endometrium which is 7 millimeters in thickness at the time of each CG trigger.
Absolutely. So that's the thin endometrium we are talking about, and we know that there are various causes related to it. So TC, can you summarize for us what really are we going to discuss on the causes? I mean, which causes you think are causes which we can treat, and secondly, which we can prevent? You're muted, TC.
Sorry. Thank you for the question. I think the key question of a thin endometrium is whether it's normal or not.
Yes.
Of course, a thin endometrium could be normal, but a thin endometrium could be abnormal too. So the key is knowing whether there is any pathology behind the thin endometrium and whether or not it would interfere with implantation. Often there are clues other than the thickness. For example, when you're doing an ultrasound examination, if the endometrium is not regular, uneven edges, loss of triple line pattern, then we suspect that there might be some problem in endometrium. And therefore, the general consensus about thin endometrium is firstly, it could be due to hormone problems, inadequate stimulation, and a number of other endocrine problems, because endometrial development depends on hormone stimulation, particularly estrogen. Alternatively, it could be due to the endometrium problem itself, like damage to the endometrium, fibrosis, adhesions, or sometimes secondary to a uterine pathology, such as multiple fibroids, adenomyosis, and so on. So I think the key question is find out if there's anything wrong with the endometrium, with the implantation process, and if there's anything that we can deal with to improving it. So I think these are the main areas of concern.
Absolutely. So I think, Jenda, you have been working on the endometrium. From your point of view, what really do you think is happening at the endometrial level, which is causing the thin endometrium?
I think underlying a lot of endometrial pathologies, not just the thin endometrium, but also the dysregulated endometrium that you see perhaps in some of those idiopathic cases of recurrent pregnancy loss, and also in abnormal uterine bleeding of an endometrial origin. I think that there is an underlying epigenetic change in the basalis that then means that the functionalis, when it regenerates after menstruation, it doesn't regenerate normally, and that's why you see these issues from cycle to cycle, because it's not just one cycle where it's wrong. This is a continuous issue. So there is an underlying fundamental issue, and I think it stems from the basalis and probably epigenetic changes within the basalis that have been induced by any number of environmental or genetic factors that then causes this long-term problem.
I think so. I think in the past we saw a lot of iatrogenic causes. I remember when we were training as residents, our seniors used to say, when you're emptying out the uterus after a miscarriage, go on scraping the uterus till you hear the scraping sound. Those days, I'm talking about maybe 30 years ago, 40 years ago. And I can imagine the amount of damage we must have caused to those uteri. I can't believe it, but I'm sure those women must have gone into amenorrhea. Anyway, we used to see a lot of tuberculosis also in our country. And I'm sure every country has different issues. There could be infections which are causing the problem. There could be basic pathologies, all kinds of causes. So I think if we proceed further and say, okay, what can we do today to that thin endometrium. We can either support it in terms of giving hormones, as TC has mentioned, and we can either give medications. So suppose I have to say that I want to treat it with medication, Eileen. You have got a patient with a thin endometrium whom you're stimulating with gonadotrophins, or you're stimulating with, letrozole, or you're stimulating with clomiphene citrate. We know we could get a thin endometrium, but when you're stimulating them for, doing an ART cycle, or even for regular infertility, what is your first step? What do you like to do in such cases? How do you handle that situation?
So if it's just a thin endometrium in a regular ART cycle, it's not reaching more than 8 millimeters in trilaminar at the time of the trigger, then you can just add a little bit of estrogen there. So we're talking about frozen cycles now, are we? So frozen
we can talk about both. You can talk about both the cycles.
Yeah. Well, if it's just a regular fresh cycle, you can increase your gonadotropins, and that will increase your estrogen level, and that should thicken the endometrium. So additional gonadotropins should do it, but in a frozen cycle, we add estrogen, of course.
And how much estrogen do we add, and when do you start adding it is another question, which I think our young doctors would like to know. And do you do any estrogen levels to determine whether there's enough estrogen in circulation?
Right, that's a good question. So in a frozen cycle, you want, as I said, the endometrium to be, your goal is to have an 8 to 10 millimeter endometrium trilaminar. So you usually have about 10 days of stimulation, and you have the leeway of giving it from 10 to 36 days. Less than 10 days, you have a higher risk of miscarriages, and more than 36, you'll have problems of bleeding. So you have enough time to do that, and we don't routinely ask for the estradiol level. That's so we just go by ultrasound thickness of a trilaminar 8 to 10 millimeter endometrium after 10 days.
Do you also tend to measure the flow on when you're assessing the endometrium, or you only look at the thickness?
I don't look at the flow unless I see something wrong. That's why the etiology is very important. If I see that the only problem is just the thickness, then I don't have to do that. But if I'm dealing with adenomyosis, if I'm dealing with endometritis, some fluid there, then I think looking at the flow is important. Yeah, so that's where another sonologist should come into the picture and have a look at that endometrium.
So if you have given estrogen and it just still is not helping, is there anything more you would like to add? Any adjuvants, anything else which would help?
Yeah, we can add sildenafil or aspirin. So this is to improve the blood flow to the area. There have been successes with these other agents, and they're not difficult to use. You can use vaginal sildenafil or your oral aspirin. You can also use HCG. Okay. At the time of, you can do it just before the transfer or the day of the transfer. You can add a bit of HCG, and that will improve the maternal fetal communication. So the crosstalk, so improve the endocrine, the endometrial tolerance. Some have used GCSF. Okay, at the time of the transfer. Yeah. And growth hormone. Growth hormone is actually useful even during the controlled ovarian hyperstimulation. So you improve on the oocyte quality, also improve on the endometrium in the process. But some would add growth hormone at the time of the transfer. So it can be given as an intrauterine infusion, or they can even inject it just underneath the endometrium, just at the time of the transfer.
So in short, there are many, many methodologies which are there, but as of today, I don't think we have a standard, sort of a recommendation or practices which everyone follows. And therefore, there'll be varied people using varied things. So TC, what is your first choice of any of these products to use for thin endometrium? How do you start off when you have difficulties with your patients?
Thank you. Well, I consider add-ons, but I seldom use them. My approach is to try and find out what is the reason behind the thinning of the endometrium, thinner than expected. Let's go back to the natural stimulated cycle, first of all. If the endometrium is not thick enough, we'll ask, is it a stimulation that is not adequate? Is the estrogen too low? Or if there is any antagonizing the effect of the estrogen. And therefore, I would routinely measure the estrogen and find a way in the correct stage of the cycle. For example, is the patient close to ovulation? And if it is, sometimes there could be progesterone luteinizing too soon, premature luteinization, and progesterone can antagonize the estrogen. So we need to check our hormone level and see whether it could be rectified in a subsequent cycle. Sometimes it's worth to changing the stimulation strategy. For example, if your natural stimulation cycle doesn't work, when you change the artificial cycle, it suddenly starts to work because you can then have a different way of stimulating the endometrium. And if you're in an artificial cycle, you should ask, am I giving the correct dose? Can I increase the dose further? Can I increase the duration more? And all these are the questions. And also, you sometimes helpful to check the progesterone. If you have unexpected luteinization, then again, the progesterone will block the estrogen effect. If you are dealing with, for example, an artificial cycle, it consistently doesn't grow, then one might have to ask a question, could it be due to an underlying endometrial problem? Then the question of hysteroscopy or checking on the endometrium should be raised before I would consider all these add-ons. Because if there are adhesions in the endometrial cavity, if you don't treat the adhesions, don't remove the adhesions, then it doesn't matter what you give, growth hormone, Viagra, everything, I don't think it will work. So I think the key issue is to systematically find out the reason why it is thin and whether there's anything simple and logical based on the underlying pathology that we can deal with. Altering the hormone profile, improving the hormone stimulation. Sometimes women may be on an artificial cycle and yet they're not absorbing the estrogen by oral route. Or they might be inadvertently taking antibiotic because they're worried about it. And some centers give antibiotic routinely before embryo transfer in women at risk. The antibiotic augmentin or penicillin can interfere with the absorption of the estrogen. And that is why we know for many years, women taking the combined pill, when they're taking the antibiotic, suddenly they get caught because the antibiotic interfere with the absorption. So I think a logical approach to finding the reason is crucial. And if there's a uterine problem, then I think the issue is either to remove surgically to remove the pathology, or sometimes if it is multiple fibroids adenomyosis, I would downregulate, shrink the little fibroids, because by shrinking the fibroid, it reduces the pressure, the compression effect on the endometrium. It gives more room for the endometrium to grow. And then suddenly you might find the endometrial grows better. I often would try these type of approaches first before considering add-on in managing the thin endometrium.
Yeah. So yes, you're very, very nicely put it. Both of you have put it very nicely together as to what you will do and how you will approach. So TC says first you determine what the cause is, what the problem is, and Eileen had added on to that as to what are the different ways in which we can tackle the thin endometrium. We have an issue with thin endometrium in terms of the women who have very scanty periods. Jenny, I wanted to ask with you whether you think that the thin endometrium, which is growing, giving rise to scanty periods, and sometimes it also gives rise to heavy periods, not that it may not. So is there any difference if a patient tells me that she has scanty periods? Then should I suspect a thin endometrium or I should not? Based on the endometrial structure, I'm restricting myself to the endometrium.
I'm actually really not too sure, because there's so many different factors that go into menstruation, and as you say, like it may not necessarily be a feature or an indicator of it, but I think if she has scanty periods and is having failure to implant, then it would definitely be something to start investigating, for sure.
Yeah, so if you see, when we find adhesions inside and there could have been some trauma inside, there would be probably some adhesions or scarring inside. Would you say that scarred tissue will not be regenerating at all? Or could we be able to regenerate it in somehow?
Well, I think it's pretty clear that where there's extensive scars, so for example, cesarean scars, that there is an absence of endometrium, because once you get into a pregnancy with a cesarean
Yeah.
scar, you know, there's a much higher likelihood that it's going to lead to an accretor, and our data on that would suggest that there are focal areas of no decidua whatsoever, which would suggest that there was no endometrium there to begin with. So definitely adhesions, scars will permanently lead to a permanent loss of endometrium in that area. That doesn't mean that
I think we lost her.
Frozen.
Yeah.
Yeah. So in the meantime, TC, I have a question for you. That you do a lot of hysteroscopies and you do hysteroscopic surgery. Do you think you can give any guidance on hysteroscopic surgery where, you're trying to get rid of adhesions, or you're doing a submucous fibroid, or you're doing any kind of a procedure through the hysteroscope? What are the tips you would give to the listeners on how you could prevent those adhesions and how you would be able to get a good endometrium even after that surgery?
Thank you, Daryl. Well, first of all, if we suspect there are adhesions inside the uterine cavity, then of course it is amenable to surgical intervention most of the time. Occasionally, when it's too badly damaged, maybe it's difficult, like Jenny mentioned. However, most cases of intrauterine adhesion could be removed by careful surgery. If necessary, under ultrasound guidance, you can remove it either by scissors or diathermy or mechanical stretching like a balloon, or by hydrodissection, as I call it, an invisible knife. There are a number of different methods you can use to remove adhesions. The key is be gentle. Don't damage the already damaged endometrium. So recognize the endometrial tissue and don't burn it away. And the second point that I want to highlight is that after dividing adhesion, removing intrauterine adhesions, there is a significant risk of recurrence because the tissue would like to regenerate by fibrosis. And therefore, we need to take steps to prevent adhesion reformation in those circumstances. There are a number of adjuvants preventing adhesion reformation, like the gel, the coil, estrogen, the balloon, and all these things. I think there are some data suggesting that it might be useful. But for now, I favor the use of a balloon distension 2 weeks after the initial surgery. Because at the time when they're trying to reform, you put in a balloon, you stretch open the cavity, and it will stretch away the fine flimsy adhesions. I find it very useful. And it's very easy to do. 2 weeks after, a Foley balloon doesn't cost much money. And then I would always consider a second look hysteroscopy 4 weeks after the initial operation to double check whether or not the adhesion have recurred, and if so, I will remove them. Second look hysteroscopy, you can often do it under an outpatient setting. You don't need to do it under a general setting. In fact, most of our hysteroscopy adhesions are done in outpatient setting, either by MAC or IV sedation, and occasionally using a no-touch technique. So that's for prevention the recurrence. And this is important because it's not just removing the adhesions, it's preventing the recurrence that counts at the end of the day. As for the initial surgery, in other words, primary prevention, in other words, in a situation where the endometrium was healthy, normal, but then you do some surgery and you damage the endometrium, then we need to be careful in not to damage the endometrium. So we need to education. We mustn't scrape the endometrium too hard.
Yes.
I know you refer to what happened 40 years ago,
terrible.
when I was a trainee, do you know how I did a D&C for miscarriage? My senior doctors would say, put up a curette and scrape the endometrium until you listen to
Yes.
some sandy sound.
Yeah.
Crack.
That is referring
That's
to.
too much. That's damaging the endometrium. So
Yes.
that is why there's so many types of adhesion, so many incidents of adhesion following an evacuation. So we mustn't do this. We have to be very gentle in doing miscarriage surgery. Suction, gentle suction, and that's enough. And of course, in high-risk cases, like when you're doing multiple fibroids, multiple polyps, then one should consider the use of adjuvant like a gel or the balloon distension to primary prevention of these adhesion. I think there's some data from Holland, from the Netherlands, that perhaps we should also consider the use of gel, hyaluronic acid gel in selected cases. I think these are adjuvants that are useful, but there's nothing more important than proper education. The next generation of doctors, be gentle, look after the endometrium, don't damage them unnecessarily.
Yes.
We are now in a stage where we talk about fertility preservation is the key.
Absolutely, absolutely. And that is why, there have been some hysteroscopic surgeons who have been doing prophylactic lateral metroplasty. Have you heard of it, Eileen? Lateral metroplasty?
No, not that.
Well, have you heard, TC?
No,
No.
tell us more about it.
So some surgeons in India are practicing lateral metroplasty, where they say it is meant for T-shaped uteri, which could help to increase the cavity of the uterus. But some of them are doing it in real indicated cases, but otherwise they're doing it for every case in which they put in a hysteroscope. And then when I have evaluated a few of those cases later, I find a lot of scarring, on the lateral side, all white, no vascularity in that area. It's completely scarred. And I think that poor patient, instead of getting pregnant, will have further infertility. So it's areas like this that which I think we need to bring out as to what is evidence-based and what is not. So the scarring is really bad. And so it comes to something like even a septum in the uterus. How often do you resect the septum? If you just happen to find it on hysteroscopy, do you resect it? Or do you say that, let me see if the patient has a miscarriage and then I will? Or do you follow some guidelines based on which you will decide when to resect the septum? So one question is this, that any surgery you do on the uterus, what is your protocol you follow to prevent the further adhesions, Stacey? You said you like to prevent further adhesions. So you give estrogen. How much estrogen? How many days? If you put in an IUD, which IUD do you put in? If you put in a balloon, how long do you keep the balloon in? These are practical points which we want people to understand. So if you all have any thoughts on any of these, each one of us practices a different way. But TC, since you do a lot of hysteroscopy, what do you suggest? What is the best protocol
Thank you, Duro.
according to you?
Yeah, for me. Well, I can say that for many years, I routinely give estrogen after adhesion surgery in the uterus. But I have to say I now stopped giving it routinely. If they have irregular cycle, they don't produce estrogen. So in a normal cycling woman, if they have enough estrogen, I stop giving them. The reason being, there have been 2 randomized controlled trials from Beijing recently, over the last couple of years, to show that routine estrogen therapy does not help to prevent adhesion reformation. So the estrogen story is now such that you don't give it routinely. So I don't. The coil, again, you look at old data, the coil really doesn't work. If you compare the various barrier methods, the coil ranks the lowest.
Yes.
Gel is okay, gel works. Balloon works better. So I used to use a balloon made by the Cook and put it inside there for about 2 weeks, 7 days to 14 days. That, however, causes a bit of problem because when you put in a balloon inside the uterine cavity, patient often complain of pain, and then the stalk comes out and it's it drop out from the vagina from time to time, and there's an infection risk.
Yes.
Now, therefore, there are a number of concerns. Practically, women don't like it.
Yeah.
And That was part of the reason why Coke has stopped manufacturing the Coke balloon, because they see it as a problem. And therefore, you can't get hold of this balloon anymore. The one method I now use routinely is using a Foley balloon, not to leave it inside after surgery, but as a distension approach. 2 weeks after the surgery, I put in a Foley catheter into the uterine cavity, only for a few seconds. I put it in, I distend it with 5 mils of normal saline. The distension of the balloon would stretch away any flimsy adhesion. So it is a way to stretch away the cavity. And then once after a few seconds, I take it out. It is cheap, it's effective, and it's fast, a few seconds. And women like it. And it really, it works very well.
Yeah.
I think in those with more than the minimal adhesions, I would go along with a second look hysteroscopy about 4 weeks after the initial surgery, because at the time, if any adhesion had been formed, you can take the opportunity and using a no-touch technique, wash away the flimsy fibrinous materials and divide the adhesions. I think with the balloon and the second look, I find the vast majority would have very good results. So my practice has changed. Estrogen, not routinely, only selective. Balloon, not the indwelling balloon anymore, but use a distension balloon just for a few seconds, 2 weeks afterwards. And I rely on second look approach. Now, I find that most of the time, women come back to you when they experience an increase in heavy period. They have the confidence. They feel happy. They know that it works because they will tell you, oh, my period is now double or triple the previous amount, and you know it works. And therefore, all these little adjuvant methods should help. That's my personal experience. I know different colleagues, different surgeons may have different preferences. But as you know, surgery is an art. It's not just a science. It's a different approaches. But that's how I would do it.
Yeah. Actually, ART is an art by itself. What drugs you use, etc. So, Eileen, you tell me, what is your preference of choice when you have to manage a thin endometrium? What is your first preference? What do you do?
Well, I totally agree with Prof. Lee. Everything he said is actually perfect. You know, I mean, you have to know what you're dealing with. I mean, it's not just looking at the ultrasound and seeing a trilaminar endometrium and all that. You have to know what the cause is. So if it's Asherman's, then you deal with Asherman syndrome, as mentioned. Now, you tell me, you do the hysteroscopy. Are you going to put in, are you going to give any adjuvant like estrogen? I don't. If I see the endometrium is developing well, regenerating well in the next 2 weeks, I don't have to do anything. But the putting in the balloon catheter 2 weeks after might be a good idea. It's something I've never done. But if I see that the endometrium is looking good after, I don't have to do anything. I don't usually give estrogen right after.
I was talking about,
which is very atrophic.
Yeah, I was talking about the medications you would use, like say GCSF or growth hormone or whatever you would like to use first.
We've used those in intractable cases, you know, with patients that you've given high doses of estrogen, and by high doses, we're talking 8 or even 12 milligrams per day. You're giving both oral and even vaginal. Vaginal will give you the highest absorption, as you know, but you usually combine it with, I usually use a transdermal because it's safer that way. And these patients you've given for, I know we can give it up to 36 days. I don't give it up to 36 days. I usually just wait maybe 15, 20 days at the most. And if not, I'm not getting a good endometrium, I stop. I would do another cycle and maybe even talk about PRP. I mean, you know, one cycle may not be good. You might want to shift to a mild, instead of an HRT cycle, you might want to do a natural cycle. If she's ovulatory, you can do a mild stimulation the next time, and that will produce a better endometrium. If those are not working, then that's the time I will introduce the issue of PRP and all those adjuvants. We've tried.
If you use PRP, which are the days when you introduce the PRP, and when do you do it?
You can do it as early as like day 6, day 8, and day 10. You can do it every other day, okay, and see if there's any improvement. Some would do it also. I think up to date. We've done it 6, 8, and 10, and improvement in the next cycle. And if it's not doing it, we can repeat, you know, every other month. And we'll see how it goes. And together, of course, with estrogen.
Yes, absolutely. So every protocol is different. So I'll come back to Jendi. We have been reading a lot about stem cells being used for regenerating the endometrium. And there are different kinds of stem cells. We know they are there. You have from the bone, you have it from the placenta, you have it from the endometrium, whatever, or from the adipose tissue. Which stem cells do you think are giving us the best results in all the research which is happening in the world?
Really not sure. Probably I think anything that's going to be able to repopulate the basales is what you're going to want, because otherwise you're still going to have to do your stem cell treatment every month, because if you're only treating the functionalis, it gets shed if there isn't a pregnancy. So what we need is something that is going to repopulate the basales and not get almost not get contaminated by what, as I said earlier, like I really have this gut feeling that there is an epigenetic component, and we've started to look at this, and we have microRNA data from women with RPL or AUBE, and so not specifically thin endometrium, but these other conditions, and there's a huge number of differentially regulated microRNAs, and so they're that are at play, and which suggests a global alteration. So I don't know which is the best source of stem cells, but it's going to be something that can repopulate the basales, so that you have a long-term change. I think TC wanted to say something to that.
Yes, TC, go ahead.
Yeah, I will use the natural stem cells in the menstrual blood. Now, Jendi mentioned something very important several times. It's always bacillus.
Yes.
If you got fibrosis, scar tissue covering the bacillus, it won't regenerate. I mean, the key is to remove the fibrous tissue covering the bacillus and allow the stem cells in the menstrual blood natural to colonize the bacillus. Then it will grow back. So therefore, if you can remove the scar tissue, the adhesions in the inside endometrium, for as long as the woman can menstruate, there are stem cells in the menstrual blood, and you could then colonize, and it will grow better and better. So we have done some experiments in CUHK, extracting stem cell from the menstrual blood. There are some stem cells. So instead of trying to work out artificial stem cell from the bone marrow, from the adipose tissue, we should use the natural stem cells in the menstrual blood. The key then is to have surgery, expose the covered endometrium, stop the fibrotic tissue from covering it. If you put in thousands of stem cells and the bacillus is covered by scar tissue, it won't work. It won't have a chance to get the bacillus to proliferate. So my theory, this is my only theory, is to uncover, open up the bacillus, allow the stem cell natural one to grow. It will get better with time, gradually. Well, I think that of course require a bit of careful surgery to do that.
There have been a lot of reports on putting in the stem cells through a hysteroscope, injecting it into the endometrium, just putting it into the cavity, which I don't think really makes sense, but they have been putting it through the uterine artery into the basalis from inside, and probably that may work, as based on what Jendi said, that you start with the basalis. Of course, you have to remove the adhesions on the top for the endometrium to grow. So still there is, it's still not sure what really works. But yes, it's a very promising therapy of stem cells, which has reported some positive results world over. There have been studies where live births have been reported, and therefore stem cells probably will be the future of how we can treat thin endometrium. There has been a lot of discussion we would have wished to do, but unfortunately, we are likely to be having some technical errors coming up. And therefore, I think we will have to wrap up the discussion in another few minutes. And my suggestion is to Eileen, do you have any interesting case which you can tell me in a minute or so as to how you dealt with her and how you got hold of her to get pregnant?
Well, I had a 42-year-old. I was able to get 3 or 4 embryos, and she had adenomyosis. We had to look at the endometrium several times. Nothing there except for some polyps which were removed. I was pretty sure we didn't have any Ashermans, no scarring there. But when we started stimulating, of course, I gave her GnRH for 3-4 months. And when we started giving HRT, there was no thickening of the endometrium. I tried prolonging it, wasn't doing it. Increasing the dose, wasn't doing it. So we did the PRP. And so there was from a 5-6 millimeter endometrium, it went up to about 8, finally 8.5, and we were able to transfer. So that was a good one.
So that is at what endometrium she conceived?
Yes, with that there was conception.
No, the thickness was how much?
The initial was 4, 5, 6 at the most, and then yeah, so I had to do extension of the estrogen, and finally after the PRP it actually worked.
Oh, very good. That's excellent. And you, TC, anything interesting?
Sorry, it's only one case that I have. Sorry.
Okay, so TC.
Okay, Duro. Well, I want to share one case, and that is
Yes.
the thin endometrium, 6 mm, nearly 6 mm, but it could conceive straight away. That is a mosaic Turner patient that I can remember when I was working in Sheffield. The uterus was small and the endometrium was thin. And she had gone through menopause because of the mosaic Turner, and she wanted to have egg donation treatment. So we got some embryo for her. The question then was, we couldn't get an endometrium to grow to 7, 8, or 9 mm. And at the end of the day, we struggle a lot. Shall we put the embryo back, which would be a waste if she's not pregnant? Yes. Shall we talk about surrogate arrangements or not? But at the time, I remember there's one thing we did. We did stimulate the endometrium, and we collect a little biopsy 7 days after giving her progesterone. And we found there were significant secretory changes. So the endometrium was thin, but normal, near normal secretion. So we have the confidence to say, well, this is a thin but normal endometrium, partly because the uterus is small, and when the uterus is small, the endometrium can't grow too big. So we put embryo back. She conceived. So the one point that I want to mention in a persistently thin endometrium, sometimes a little simple trick to work out whether it's a thin but normal endometrium is to do a biopsy 7 days after the progesterone therapy, or 7 days after ovulation, so to speak. If there are good secretions, then it means it's likely to be thin but normal. But if the endometrium doesn't show any secretion, it's only proliferative, you know, you got a problem. You put the embryo back, it's not going to implant. It will be a waste of time or waste of embryo. So I find that quite useful, and I have used that little trick to help patients on a number of occasions. Something that I want to share with you. So don't forget the secretory changes in endometrium.
That's really interesting. I think it's very good. And yes, there was one very important thing which also I wanted to discuss, but sorry because of time, but I'll just mention is chronic endometritis. We do hysteroscopy, we see multiple polyps inside, and we think it's polyps, and people try and remove them. But actually, when they do a molecular testing of that endometrium, you'll find it's chronic endometritis, which is causing that polypoid look. And we just need to get the molecular diagnosis, treat the endometritis, and everything straightens out. So these are various little tips which we wanted to discuss. But yes, probably we'll take it up in another episode. But today we'll have to close. I'm so sorry that we have to close prematurely. But thank you very much for being with us. And whatever questions do come in, We'll share it with all of you, and we'll send out the answers. And I'm going to request the team to give us one more series for this very, very important discussion, which we want to take further. Thank you very much for being with us, and thank you, delegates, for being with us. Thank you.